Let's start with the lesion. Okay, lesions of temporal lobe. Temporal lobe. So the lesions of the temporal lobe will be, as we all know, temporal lobe is concerned with the auditory. Okay, auditory sensation. So first and foremost, disturbance will be in language and speech. Language and speech. The second one is there will be issue with the sensory interpretation. Sensory interpretation of many sensations. Third, hippocampus and amygdala. There also hippocampus is the part of temporal lobe, so there will be impaired memory. So these three main issue will be the language disturbance, the sensory interpretation disturbance, and the memory disturbance. And let me tell you, like these lobes, we have divided the cerebral hemisphere into different lobes, like the frontal, parietal, temporal, and occipital, for our own convenience. It's not like the anatomical classification coming by the birth, like there are the sulci which says this is the separate part. All these different lobes, they are just part of one cerebral hemisphere. We have divided based on few of the sulci, like the three major sulcus, the central sulcus, the lateral sulcus, and the parieto-occipital sulcus. Based on those few areas, we have earmarked them. Like in the case of the parietal cortex and the parietal lobe and temporal lobe, they do not have the clear-cut margin in most of the boundaries. So few of the areas, they are present in the parietal lobe, as well as they are also present in the temporal lobe, right? So like say Wernicke's area, it is present in the temporal, major chunk is present in the temporal, but a bit of this is also present in the parietal lobe. Similarly, there is one gyrus that we will now discuss, that is a fusiform gyrus, right? The fusiform gyrus. This fusiform gyrus is present mostly in our temporal lobe, but a bit of it is also present in the occipital lobe. So few of the functions, they are of not only a single lobe, they are of multiple lobes. So like the sensory interpretation, major function of this temporal lobe is auditory area, like the auditory cortex, and language and speech is concerned. Mainly it should be about the hearing, but it is also helpful in the language, because the Wernicke's area is connected with the Broca's area, and whatever the ideas, like to speak something, that idea formation occurs with the help of the Wernicke's area. Okay, so now coming to these three, what we said, there will be the disturbance in the language, there will be disturbance in the sensory interpretation, and there will be disturbance in the impaired memory. So if we talk about like the primary auditory cortex, first and foremost was the primary auditory cortex. What was the function? Primary function, hearing. So if there is any issue with the primary auditory cortex, if there is this lesion that's involving the primary auditory cortex of one side, if it is involving of the one side, there won't be any much difference in the hearing capacity of a particular person, because these auditory pathways, you will read in the special senses, the auditory pathways from medulla onwards, their projection is bilateral. Like say if it is coming from the right ear, it will go to the right cerebral hemisphere, primary auditory cortex, as well as to the left. So the representation is bilateral. Okay, so the representation being bilateral, if one side, one lesion happens say on the left aspect, there won't be much effect on the right side. So if there is any lesion affecting the primary auditory cortex of the left side or the right side, there won't be much disturbance in the hearing capacity of a particular person. At the max, that hearing capacity will be, that person will lose the sense of source of the sound. Like in the case of the, what was the function of the primary auditory cortex? The sound perception. And in the sound perception, it was regarding the hearing, like say loudness, pitch, source, and direction. say there is a lesion in the right primary auditory cortex, okay, then the contralateral ears, the left ear will, if any sound is exposed to the left ear, that person will hear it normally. The only issue will be with the location of the source of the sound, okay, source of the sound or the direction of the sound, that is the max that will get affected. So until and unless both the right as well as the left primary auditory cortex, both of them are not involved, there won't be much effect on the hearing. If both of them they are lesion, then there will be total deafness, okay, that's one point. The second one is, now coming to this one, Wernicke's area, okay, that was the second point, Wernicke's area. So in Wernicke's area, because this is sensory speech area, this is sensory speech area, and by the sensory speech area it means whatever the things are said that are to be understood. So if the person is suffering from, this is area number 22, right, area number 22, Wernicke's area. So if a person's dominant hemispheres or categorical hemisphere, that happens to be in majority of the person left cerebral hemisphere, if that is having some issue, lesion within the dominant hemisphere, area number 22, then there will be Wernicke aphasia. What does it mean? It means there will be loss in the sensory speech area. So the reception will be lost. Patient will not be able to understand any form of language. Like whatever I am saying, you will keep on hearing it, but you won't comprehend or understand this language. But the speaking capability of the person, that faculty won't be compromised. So person will keep on speaking normally, there will be fluency, no loss in the fluency, fast fluent speech will be there, but that won't be comprehensible because that person, he is not aware about it. That person who is suffering from the Wernicke's aphasia is not aware about like any abnormality. That person doesn't know, he isn't aware that he is having this issue. He will keep on listening something, he won't comprehend, but he will keep on speaking anything. So on a lighter note, we can say, I can say like everybody has got one or two friends in his or her friend circle जिसको Wernicke's aphasia है, right? On a lighter note I am telling you, बिकॉज से होंगे आपके कोई ना कोई फ्रेंड जो सुनता ही नहीं है, आप कुछ भी बोलते जाओ, या तो सुनता ही नहीं है, समझता ही नहीं है, वो अपनी बोलता रहता है, अपने ही उनमें कुछ भी बोलता रहेगा, कुछ भी आप कुछ भी बोलते रहो उसे, उसको अपना बोलना है. सो दैट्स द Wernicke aphasia, easy to remember, right? So that was the second one. Now coming to the hippocampus. Hippocampus is also the part of the this one temporal lobe. So if there is, first and foremost, there should be the bilateral lesion. If anything happens related to the hippocampus, if there is bilateral lesion, then the person won't be able to consolidate the short term memory into long term memory, because the hippocampus is the one which helps in consolidation of short term memory to the long term memory. Don't worry about these like detail how these memory are from the short term to long term is converted. We will have a separate class for it. Okay. So for the time being, remember, if there is bilateral lesion of the hippocampus, there will be inability to consolidate short term memory into the long term memory. Now amygdala was also there. So if the amygdala, similarly like the hippocampus, if there is bilateral lesion of the amygdala, if there is bilateral lesion of amygdala, then what will happen? Then there will be one constellation of the symptoms, and that thing is called as, that particular term for those constellation of symptoms, that syndrome, that is called as Kluver-Bucy syndrome. This Kluver-Bucy syndrome is a constellation of symptoms, and those symptoms will be, first and foremost, will be hyper orality means if the person is suffering from the bilateral lesion of the amygdala, he will have tendency to put anything, each and everything into the mouth, that is called as hyperorality. Second thing, there will be hyperphagia, will keep on eating the things. Okay, hyperphagia. Then there will be hypersexuality, sexuality. Okay. Then there are few other things, like because amygdala, I said this is related to the emotions, so that person suffering might have apathy. Okay. And then there might be some, because this amygdala, this has got concern or connection with the occipital lobe, then there will be one agnosia. That agnosia is called as visual agnosia. You know what is agnosia? Agnosia is inability to sense a particular sensation, inability to perceive the sensation. Depending on, say, visual agnosia, this person, first let's complete this Kluver-Bucy syndrome. So, Kluver-Bucy syndrome is due to the bilateral lesion of the amygdala. Bilateral lesion should be there. The person will have hyperorality. Whatever the thing is in his hand, he will try to bring it to the mouth, hyperorality. Second thing, hyperphagia. Third thing, hypersexuality. Fourth thing, apathy. Fifth one, visual agnosia. Now, I was telling about the agnosia. Agnosia is inability to sense, perceive a particular sensation, despite that sensory modality of that sensation being normal. Say visual agnosia. Visual agnosia means that person, his or her eyesight is perfectly normal. Retina, the entire eyeball, including the retina, rods, cones, lens, cornea, everything is functioning perfectly fine, as well as the optic nerve, optic tract, everything is perfectly fine, but the interpretation of that sensation that's coming via this visual pathway, that won't happen. So, that person won't be able to recognize the subject or any object in his visual area. So, that's called as visual agnosia. Okay, visual agnosia. Similarly, if there is any agnosia related to the, say, speech, then we will call it the auditory. Okay, auditory agnosia. So, these are the symptoms of Kluver-Bucy. Okay, Kluver-Bucy syndrome. Now, because I said the olfactory bulb and tract, are also the part of it. So, if there is lesion ipsilateral, if say left sided is happening, then the same side, because these they don't cross over. So, there will be ipsilateral anosmia or hyposmia, means loss of smell. Anosmia, total loss. Hypo, not the total, not the complete absence, but loss of the smell will be there. Despite being the loss of the smell, it won't be complete loss. Okay. So, that is regarding the olfactory bulb. Now, I guess the eye vision has started. One of the faculty is taking the classes of the eye. So, you will read about this optic radiation. Let me tell you one thing. Say, I will just try to draw the diagram of this one, the concerned part with this temporal lobe. Say, this is the retina. The object formation, the image formation of the object in the retina, because of the lens, is inverted, right? You know about this thing. And again, from there, it goes from the medial aspect will go this way, and the lateral aspect will go this way, right? So, if we say this part of the field, left part of the field in this one, both the eye, it will go to the right side, right? Because if we trace this pathway, this one. So, left in the field of the vision, left side goes to the right side, or we can say right part of the retina. This is the retina, right part of the retina is going to the right side, but the left side of the field of the vision is going to this one. Okay. So, these optic radiation, if we enhance this part from the this one lateral geniculate body, it goes to occipital cortex, optic, like the optic nerve, optic tract, and then those optic radiation they are in, like these are the radiation, this is going to the occipital cortex, say this is the occipital cortex, it will go. Now this part, the upper part, this goes via the parietal lobe, parietal lobe, and this part, it is called as Mayer's loop. Okay, Mayer's loop. It is a long pathway, like it will go through the temporal lobe, like downward. So it takes a long loop, circuit, long circuitry route. That's the Mayer's loop, and direct pathway of optic radiation goes via the parietal lobe. So what is the difference? Like these tracks, say, like there is a topographical point to point representation of entire body in the motor and sensory homunculus. Similarly, there is topographical representation of point by point of the retina on the occipital cortex. So this Mayer's loop, that was going via the temporal lobe, and the direct one that was going, the upper one, the upper track was going through the parietal lobe. So the Mayer's loop is the lowermost part. So this lowermost part of the optic radiation, it carries the sensation from the lowermost part of the retina, lowermost part of the retina. So if I try to draw the diagram again, say this was the eye, retina, and the object formation, image formation was happening this way, and this was going this way. Say this is the Mayer's loop. Okay, if this is the Mayer's loop, the lowermost part of the retina, so lowermost part of the retina of this part and this part. Okay, so this retina, and in the retina the image formation of the subject is entirely opposite. Say if this is the lowermost part of the retina, in the visual field it will be the uppermost part. Okay, similar, like say the right side of the retina is in the left field of the right side. Say this is the right side of the retina. Okay, so the image formation of this left part of the field of the vision is happening on the right aspect. Similarly, if this right aspect of the field of the vision, the image of that will form on the this aspect, the left aspect of retina. Okay, the left aspect of retina. So its image is totally inverted, not only via this one direction on left or right, but also in the horizontal axis, means the image, the upper part, the superior part of the object in the field will form the image on the inferior aspect of the retina, and inferior aspect of the field of the vision will form image on the superior aspect of the retina. So this lower Mayer's loop, it is having the fibers which are coming from the lowermost part of the retina. It means it is representing the uppermost part of the field of the vision in this aspect as well as this aspect. So if I try to draw, this is the field of the vision of one eye. Say, let me delete this thing. Okay, say this is one field of the vision, and this is the second eye. This is the right sided, and this is the left sided field of the vision. So this is the superior most aspect of the field of the vision that will be carried via the left sided Mayer's loop. So if this Mayer's loop is left sided is getting affected, then there will be loss of the vision in this superior aspect, So this is called as contralateral side, like opposite. Say this is the left homunculus is getting affected in the field of the vision, right aspect, superior, right superior pi. This is called as pi in sky type of the scotoma. You will read about this pi in sky type of the scotoma in vision chapter when you will read about those optic radiation and all. So, if the Mayer's loop is getting affected, there will be pi in the sky or superior quadrant nopia, means superior most aspect of one quadrant is getting affected. And if there is lesion in the parietal lobe radiation, then it will be totally opposite. There will be inferior quadrant nopia, okay, quadrant nopia. It means if I try to draw the diagram like this way, it will be not this part, sorry, not this one, it will be this part. Pi, this is called as pi on floor, like pi in sky, this is pi on floor type of loss of field of vision. Okay, that will happen if these Mayer's loop and those optic radiation, if the optic radiation in the parietal lobe is involved, pi on the floor. If the optic radiation in the temporal lobe, that is called as Mayer's loop, then there will be the pi in sky or contralateral upper quadrant nopia, contralateral side. Okay. So, that was regarding this optic radiation. Now, I said the fusiform gyrus, right, the fusiform gyrus. This fusiform gyrus, it is majorly, it is like, say, if I draw the diagram of this, this is the temporal lobe, this temporal lobe, the posterior most part of the temporal lobe and a small part of the occipital lobe, this is the fusiform gyrus. So, this fusiform gyrus, this is concerned with the recognition of the faces, recognition of a particular face. So, if there is lesion in this fusiform gyrus, the person won't be able to recognize a particular individual by just looking at the face, because this area is concerned about the facial image formation and then interpretation of that facial image and remembering. Okay. So, that thing is called as, that disability is called as prosopagnosia. Gnosia is loss of any particular sensory modality. No, without being the sensory modality getting affected, the person is unable to perceive a sensation. So, this prosopagnosia means that person is not able to perceive the particular individual's face. So, like say, मैं किसी आदमी से 3-4 बार मिला हूँ, कुछ एक लोगों में होती है ना ये कि यार मेरे को फेस याद रहते हैं, फेस याद नहीं रहते. फेस याद नहीं रहते मीन्स वो तो एक कॉमन है, दैट्स क्वाइट कॉमन, दैट्स नॉट द अबनॉर्मैलिटी. कुछ लोगों को ज़्यादा याद रहते हैं, कुछ को कम रहते हैं. बट अगर सीवियर हैम्परिंग हो रही है आपकी, मान लो कि आप अपने फ्रेंड्स को ही पहचानने से वो मना कर देते हो, आपको पहचान ही नहीं पाते हो, बाय जस्ट लुकिंग एट द फेस यू विल बी एबल to identify that person by hearing the voice, because that sensory modality is perfectly working, only the face recognition part is not working properly. So, you can identify the person by just hearing the voice or by just the smell of that person, but you won't be able to identify the person by looking at the face. So, face recognition inability, that is called as prosopagnosia, that happens due to injury to the fusiform gyrus, any lesion involving the fusiform gyrus.